Good afternoon, everyone, and welcome to the 30th Labelle Lectureship in Health Services Research. My name is Alex Cerna, and I'm a PhD student in the Health Policy PhD program here at McMaster University, and I will be your MC today. We'll begin by giving honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the lands where McMaster stands. To say that is to acknowledge a debt to those who were here before us and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have to this land. It's wonderful to see a large turnout to this year's Labelle lecture. While we're still in the middle of this pandemic, and while this year has no doubt been trying for many of us, it's also given us some opportunities, one of which is to have our Labelle lecture online. And although I wish we were all here in Hamilton in person, the online format means that we have people joining us from all over the world who might not have been able to be here otherwise. So welcome, everyone. At this time, I would like us to test the chat box. Please open it up and write down your affiliation, and let's see where everyone is joining from. Okay. Lots of McMaster folks, Dr. Tiffany Green from the University of Wisconsin-Madison, who was our Labelle lecturer last year. Thank you so much for joining us this year. Folks from CADIF, Ministry of Health. Okay, wonderful. Thank you so much. Close that up. Okay. It's amazing to have such an interdisciplinary and multidisciplinary audience filled with students, working professionals, faculty at various stages of their careers. It really speaks to the nature of the Labelle lectureship. We will now begin our event with words of welcome from Professor Jean-Éric Taride, who will tell you about the Labelle lectureship series in further detail. He'll be followed by Dr. Julia Abelson, who will introduce the highlight of today's event, the Labelle lecturer, Professor Jay Shaw, who will then be followed by a presentation from our discussant, Professor Sarah Lau. We will have time for questions after Professor Lau's presentation and her questions for Professor Shaw. Some housekeeping rules for Zoom. Please keep yourself muted throughout the discussions today. Speakers, I ask that you unmute yourselves when you're introduced and then mute yourself when you're done speaking. During the question period, please type your question in the chat box and I will read them out to our speakers. Feel free to chat amongst yourselves in the chat box or at the top, write your questions there. I will be monitoring the chat periodically. And finally, this session is being recorded, so just please be aware of that. Now, without further ado, I would like to introduce Professor Jean-Éric Taride, who will talk to you about the Labelle lectureship series. Dr. Taride is a professor in the Department of Health Research Methods, Evidence, and Impact, and the director of the Center for Health Economics and Policy Analysis, or CHEPA.
Thank you, Alex, and good afternoon to everyone. It's my great pleasure to introduce the 30th Labelle lectureship. So Roberta Labelle was one of the CHEPA founding members. Her death in 1991 was unexpected and occurred when broad recognition of her research in health economics was just starting to emerge. In memory of Roberta, CHEPA and the Department of Health Research Methods, Evidence and Impact collaborated on establishing the annual Labelle Lectureship Series. The Labelle Lectureship is awarded annually to a young investigator of promise, engaged in multidisciplinary health services research with challenging existing methods or accepted ideas in the field. Past lecturers include the likes of Andrew Jones, Peter Singer, Colin Froud, Mark Skolfer, Jennifer Pressburger, Steve Morgan, Michael Lowe, David Stuckler, and Tiffany Green. Back to you, Alex.
Thank you, Dr. Taride. I would like now to welcome Professor Julia Abelson, who will introduce our Labelle lecturer. Dr. Abelson is a professor in the Department of Health Research Methods, Evidence, and Impact, the director of the Health Policy PhD program, and the former director of CHEPA.
Thanks very much, Alex. Really great to be here and a warm welcome to all of you. It's my great pleasure to be part of the 30th anniversary of the Labelle Lecture and to be in the position to welcome and introduce our 2021 Labelle Lecturer, Dr. Jay Shaw. As is common for many of our Labelle lecturers, if you've had a chance to get to know them a little bit through the introductory piece that we had just before we started, Dr. Shaw is an interdisciplinary scholar, so like many of our previous Labelle lectures, interdisciplinary very much in his training and how he approaches his areas of research. He has training in rehabilitation sciences and expertise in health policy and ethics and science and technology studies. He earned his PhD in health and rehab sciences from Western University in London, Ontario in 2012. Prior to this was a practicing physical therapist in community-based care, which I think is a really interesting way for him to kind of tackle the topics he'll be contributing to today. He holds a faculty appointment currently in the Department of Physical Therapy at the University of Toronto in their Faculty of Medicine, and also holds other appointments, including one as scientist at the Women's College Hospital Institute for Health System Solutions and Virtual Care. And he's also the research director of AI Ethics and Health with the Joint Center for Bioethics, also at the University of Toronto. Dr. Shaw's program of research, which he'll of course be drawing on in his lecture today, addresses the implementation and ethical implications of innovations in healthcare, lots of eyes there. Clearly a relevant topic and an important topic to us all. In looking at his CV, one sees very quickly a long list of awards and accomplishments, which clearly point to his rising star status and suitability for this lectureship. These include federally funded training awards and peer-reviewed funding as PI from both SSHRC and CIHR, which I think is quite notable and demonstrates his interdisciplinary strengths and abilities. He's publishing in leading digital health journals, in particular, including a newly established journal titled Nature Digital Medicine, and really seems to be able to balance a very impressive publication record with extensive and a wide array of knowledge exchange activities and a growing list of expert advisory roles. It's in this latter capacity that I wanted to just make a couple of comments. He's currently sitting on a number of working groups provincially with the Ontario Ministry of Health, nationally with CADTH, or the Canadian Agency for Drugs and Technologies in Health, and internationally contributed to the development of the WHO's guidelines on the ethical governance of AI for health. So clearly in a superb position to be speaking to this topic today. He will be addressing in his talk today an important and I think suitably provocative question for the Labelle lecture: will innovation save healthcare? I'm especially looking forward to his reflections on what responsible innovation that promotes inclusive care might look like. And so with that, I'll extend a very, very warm welcome to you, Dr. Shaw, and invite you to give the 2021 Labelle lecture.
Thank you for that very generous introduction, Professor Abelson. I will go ahead and share screen. And I have a couple of introductory comments, but very first, I would like to give a land acknowledgement. I appreciate a land acknowledgement was given for the territory on which McMaster stands, but I give this talk from Toronto, which is the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, and of course is now home to many diverse and Indigenous people. And it really is a privilege to live and work here. And I want to just quickly add that connecting this to some practical activity happening toward truth and reconciliation, I would encourage attendees to just type into a Google browser the Center for Wise Practices in Indigenous Health. This is a group at Women's College Hospital doing really important work toward truth and reconciliation. There's a variety of resources on their webpage, and you can learn a bit more about some of the activities that they're getting up to. So what an honor. Amazing to sit here for 10 minutes and see the past Labelle lecturers and learn a bit more about Roberta Labelle and her orientation to her work and to her colleagues. In the exchange leading up to today, I saw the word feisty appear quite a few times, and I hope that we can live up to having a provocative and interesting presentation and exchange. I know Sarah has some interesting responses to some of the work. We've had an opportunity to connect in advance, and I really appreciate Sarah giving the time to engage with the content as she has. So this is an opportunity to be iconoclastic, to go against the mainstream message about a core topic in health services and policy research. And for me, that's health innovation. So that's what this is. This is an experiment in thinking differently, bringing new perspectives to this topic. Now, I was instructed to aim to speak for about 1 hour, and I will keep my eye on the clock. We're at 3:15 now. And I want to encourage everybody listening in to just be comfortable, do what you need to do throughout the talk, tune in, tune out, and hopefully you can join us for some discussion when the talk is finished. Also, deep thanks to O'Neill Bhattacharya, a past Labelle lecturer who nominated me for this. So I'm deeply appreciative of that. And just another point of connection, I draw on Pascal Lahou's work quite a bit in my own work and in this lecture. So we'll see a connection to the past Labelle lectures in that way as well. So, focusing attention then on the screen in front of us for an outline today, I'll talk about the demand for innovation in healthcare, what generates that demand, and why innovation is viewed as a solution to the problems we face. I'll give a definition of health innovation and then complicate that definition a little bit. And really the bulk of this session is about these challenges to innovation in healthcare as a public good. And they revolve around this question of who is served by innovation in healthcare. These 5 challenges, to give an overview quickly. First, overinvestment in new technology. Second, the role of big tech corporations in healthcare. Third, the digital divide. Fourth, underinvestment in solutions to upstream determinants in health. And fifth, lack of attention to infrastructure. And in my previous discussion with Sarah, she posed the challenge, well, how are these distinct? So hopefully that becomes clear, and we'll have some dialogue about both how they're distinct and how they're connected afterward. And then I'll outline responsible innovation as a way forward, an approach to addressing health innovation that does serve the public good. So in terms of the demand for innovation in healthcare, I like to situate this discussion in these broader global trends that are shaping life in so many ways, and that includes their convergent influence locally on healthcare systems and healthcare services. So these are global trends, and I'm sure this is not the first time you've heard these referred to. Globally, there's an aging population. Technology is changing at an immense rate. And of course, a large part of my work is about understanding the implications of new and emerging technologies for healthcare. Growing economic inequities, as we've seen so deeply pronounced during this pandemic. Immense pressure in housing markets, which drives people toward precarious housing and experiences of homelessness. And these have profound impacts on healthcare systems, and I'll say a bit more about that today. And then, of course, to state the obvious, a global pandemic. So these things converge in their influence on healthcare systems. And this current government in Ontario came into power with an apparent mandate to end what they referred to as hallway healthcare, hallway medicine. But this, of course, is a longstanding challenge of how to manage busy emergency rooms when there are backlogs throughout the healthcare system. And these each contribute in different ways to those challenges of promoting a culturally safe, effective, and efficient health system. So I'll just give 2 examples to give some data to back up the existence of these trends and their impacts. This is a paper published this year in the Canadian Medical Association Journal on trends of chronic disease and multimorbidity here in Ontario. And these authors found that between 2008 and 2017, the number of people with 1 or more chronic disease increased by 11%. So that's an additional 1 million people with a chronic disease in that time frame. Those with 3 or more chronic diseases increased by 13.5%. That's an additional 500,000 people. And these authors propose that higher prevalence of chronic disease is driven primarily by population aging. So we see, this connection between population aging and chronic disease. Now, my colleagues in critical gerontology would be very quick to dissociate chronic disease from the experience of aging. And it's important that we acknowledge that as well. However, the total number of older people, as this project demonstrates, is associated with higher prevalence of chronic diseases and multimorbidity. Now, of course, this means more acute exacerbations of chronic disease. It means more community-based care to support chronic disease management in the home and in the community. So this means more healthcare. So this creates these additional demands placed on healthcare systems, which produce the need for health innovation. And I'll say more about that. A second of two examples to sort of frame this, the impact of these trends. Another paper recently published on the experiences of people with recent history of homelessness during COVID, during the pandemic. These authors, led by Lucy Richard, found people with a recent history of homelessness were more than 20 times more likely to be hospitalized with COVID-19, more than 10 times more likely to receive intensive care, and more than 5 times more likely to die within 21 days of a positive test. So obviously, experiences of homelessness and the economic inequalities that drive that are deeply connected to the experience of the pandemic, the experience of COVID-19, and the impact that has on healthcare systems. So we see that these trends are convergent in their influence on healthcare systems. They create new and novel demands on healthcare. And so the question becomes, what do we do? And this is where health innovation enters into the game. So health innovation is a response to this. If the system is unable to meet these demands, it will go bankrupt. That's not an option. So we need to think in radically different ways about what the healthcare system does and how these needs can be met. So I tend to draw on the World Health Organization's definition of health innovation, and I'm giving kind of a partial view of that otherwise fairly long definition in 2 different sections here. So first, the WHO says that health innovation identifies new or improved health policies, systems, products, and technologies, and services and delivery methods that improve people's health and well-being. So this is sort of everything. A new or improved anything constitutes health innovation. But I think this is important because it illustrates that health innovation is not only about technologies, it's also about a policy that accomplishes something new, thinking through a local system of care that better meets needs. Yes, of course, products and technologies, but other things too. The WHO continues their definition to say that health innovation responds to unmet public health needs by creating new ways of thinking and working with a focus on the needs of vulnerable populations. And while I think this is important and aspirational, certainly not all elements of health innovation could be cast as serving the needs of so-called vulnerable populations. So this is a well thought out, comprehensive understanding of health innovation. And I would pose the question, but what do we really think health innovation is? Like if you typed healthcare innovation into a search bar right now, what would come up? And so to sort of answer that question, you would get things like this, a consultant report on the top 10 healthcare innovations from Time Magazine and Forbes Magazine, examples of innovations that will completely change healthcare. And these are all focused on new and emerging next generation type of technologies, many of which, or most of which, are digital in nature. And so for me, these represent our imaginaries of innovation. When we close our eyes and think about health innovation, it's these kinds of things that tend to come to mind. I'm speaking, in the royal we here, but I want to suggest that popular conceptions of health innovation are dominated by this kind of thinking, as opposed to this broader understanding of health innovation that the World Health Organization would propose. And this idea of imaginaries, the assumptions, beliefs, and visions around health innovation that predominate in our mindsets, I think is helpful for encouraging us to identify what that imaginary is so that we can step away from it and perhaps open up new avenues for change. So is innovation achieving its aim? And here I will move into sort of the primary section of the talk outlining these 5 challenges to a version of health innovation that adequately meets the needs of diverse publics, that's inclusive and serves people, especially those who are so-called underserved. So we'll get started with this point around overinvestment in new technology. And I'll refer here, I'm going to spend some time talking about this image. This comes from some of Pascal Lahou's work, where her and her team have looked at the influences on the value proposition of a new health technology. So a new technology is developed, the idea comes, a prototype is developed, but the value proposition represents where in the healthcare system that technology is to fit. What need does it address? What value does it add? And although the innovator, the entrepreneur, has an idea of that value at the outset, that value can change over time. And from the work I've done at Women's College Hospital, we've certainly seen where that's the case, where it changes over time. So I'm going to start by talking a little bit about this on the left of the screen, innovation policy. So in this image, innovation policy refers to what's described here as supply side logics. So this is about innovation to support economic gain. This is financial markets, business, media, the effort to promote new ideas, the commercialization of those ideas in order to stimulate economic growth. So, very important policy. It's a domain of policy. It's characterized the OECD, Organization for Economic Cooperation and Development countries, and the global policy on innovation for a long time. On the other side, the flip side of this coin, we have health policy. And fundamentally, health policy is about building and sustaining a health system that can adequately meet the needs of the people it's intended to serve. So in relation to this notion of a value proposition, health policy is about, as Lahou and colleagues refer to it, demand side logics. So this is about who's reimbursing this particular technology, how is it being procured? And that relates very closely to the need that's being addressed on the healthcare policy side. So innovation policy and health policy, in this case, we may find that there's fundamentally a tension between them. And this is a theme that will come back throughout the talk. So if we look at entrepreneurs, on the innovation side, of course, they influence the value proposition of a technology. They come up with the idea, they push forward the initial prototypes. It goes without saying. Regulatory agencies, this is the mechanism on the health system side of things to make sure that technologies are safe, that they aren't causing undue harm, that they aren't unduly expensive. These regulatory agencies perform a crucial safety function. And then, of course, capital investors. And this overinvestment in new technology, I'll be saying a bit more about this piece, capital investors. And this is because I think that this is something that tends to be overlooked. It's hidden from the conversation about digital health and healthcare innovation as a public service, as a public good. So just to clarify this a bit further, I want to add a couple of quotations from this paper that I'm referring to here. So in terms of this tension between these two sides, Lahou et al. Say, one may wonder about the way that innovation policy and health policy, which value different outcomes and operate according to different logics, affect the development of new health technologies. So we see this tension here. What does that mean for what technology is doing? And there's this really clarifying quotation from some qualitative research that they report in this paper, which I'll move on to now. So they say, this is from an investor, a portfolio manager. And this quotation is, we're portfolio managers over 10 investments in general. There's one that will bring in 20, 30, 40 times our bet. There's going to be 2 or 3 that will go bankrupt. And with the other 6, either we'll lose a little or we'll recover a little more money. So basically for us, it's the average, it's the batting average. My shareholder will be happy if, say, that with the 100 million that I'll put in, I don't know, in 10 to 12 investments, these are arbitrary, I bring back to my shareholder 120 to 130 million. This is when they're happy. So this illustrates this point that investors significantly alter the value proposition of these technologies. They change the logic about what the technologies are supposed to accomplish, because fundamentally for capital investment, it's about finding a customer. So, I start with this point about this tension between what digital technologies and the innovation of new technologies intend to achieve and what the needs are in the health system, because I think this tension really frames the possibilities of a responsible innovation for health. And we'll be revisiting this as we continue on. So just to sort of conclude this first section and hopefully bring this point home, I want to pose the question, where is this investment happening? What are the technologies that are being invested in that we need to be watching out for? So I show this image, which is a visualization of work done by this market research firm, CB Insights. Each year they produce this, what they call Digital Health 150. They look at 150 digital health companies that are to watch in the coming year. So this is from 2020. They're just producing the 2021 version now. And on the right side, I've added a red square around virtual care delivery to raise this point that there are 16 companies there, and certainly many more virtual care delivery companies in existence right now. And it's raised concern throughout the pandemic that the proliferation of virtual care companies may actually be damaging the possibility of coordination in the health system. So the question that I would pose is, these may have customers, but with what effects on health systems? So as we contemplate investment in these technologies, where the investments go, the motivations behind those investments, I think we need to look at the demand side and pose this question: what are the effects on coordination and fragmentation? What effects do these investments have on health systems? So that's just concluding that first section, overinvestment in new technology. I think that was the most dense of the 5. So we'll move along to a somewhat simpler overview of the role of big tech in healthcare. So when I say big tech, I suspect you know who I'm referring to. And Facebook can't trick us. We know what you are, even if you change your name. And in the global outlook, the role of these large technology corporations in healthcare, I think, is really crucial to understand. But given the context for this talk, I'd like to just refer to the circumstances in Canada, particularly around large technology corporations involved in virtual care delivery here in Canada. And I place these logos, Well Health Technologies, George Weston Limited, and TELUS Health up here, because these 3 corporations make up a substantial portion of the market share for the $10 billion industry that is virtual care technologies in Canada. And so, as much as these real big tech corporations represent an important domain of study on a global scale, and that includes here in Canada, we also have these other kinds of companies that are investing very deeply in the digital health and virtual care ecosystem. So the question for me is about what happens when governments need to change direction. If private technology corporations, with a huge number of customers, are providing services across Canada and internationally, and they own the infrastructure and the service being delivered in our healthcare system, what happens when policy needs to shift? And here's where I would introduce the notion of regulatory capture. From an interdisciplinary review on the topic, Labelle defines regulatory capture quite simply as the process through which special interests affect state intervention in any of its forms. Now, this is more of a suggestion than any kind of conclusion, but I would say that as these corporations establish greater control over the ways in which virtual care services are delivered, there needs to be close attention to the prospect of their potentially deep influence over domestic healthcare policy. So that's a provocation that I bring to this particular stage. Now, to shift attention back to the United States, which of course, big technology corporations in the United States are really driving much of the digital innovation that we see spreading around the world, I wanted to give an example of this regulatory capture. In 2019, Google hired both the ex-commissioner of the Food and Drug Administration and the ex-national coordinator for the Office of Health Information Technology. These are two extremely influential policy positions. These were people who were hired by Google to help oversee their health portfolio. So, that means that these individuals, not only their knowledge and skill set, but also their professional networks come to the service of Google. So this is the mechanism by which technology corporations exert their influence over policymaking processes, or at least one of them. So final slide on the role of big tech is just to point to some amazing work that's been done on this topic. Tamar Sharon is a philosopher in the Netherlands, and she's written about this in the context of the Apple-Google API for contact tracing during the pandemic. And then some scholars from here in Ontario, Dylan Walmsley and Ben Chin Yi, have also done some really exciting work on this topic as well. The role of technology corporations in influencing healthcare policy. So I pose that as a provocation for the role of big tech in healthcare. I'll move on now to discussing the digital divide. And this quite simple overview definition comes from one of the leading scholars of the digital divide, Van Dyke, who describes the digital divide as the gap between those who do and those who do not have access to new forms of digital technology. So I think this often is in people's consciousness as the divide between older people and younger people in terms of their engagement with technology, or those who live in rural areas and those who live in urban areas. And certainly there are divides, not quite as simple as that, but there are divides that exist in that domain. But this is a multidimensional intersectional phenomenon. Now, this is a bit of an oversimplification, but is really a synthesis of lots of work on the digital divide that proposes there are these different levels of the digital divide. And so I'm going to outline these three. So first is simply access to internet-connected devices. So the first level of the divide is simply about access. Do people have an internet-connected device through which they can engage with online services and information search? Step one. Level two is whether people have the literacy to use those devices in effective ways. So simply having a device is not helpful if you don't know how to open up a search bar and acquire the information that you need. And then third is about having the capacity to convert those two into outcomes that matter for your life. If you're engaging in a search for a new job, and you have the device and you can search for those, search for job postings, can you execute the job applications and learn more about the interview process such that you can actually go and successfully accomplish those job interviews? So 3 layers to the digital divide. The digital divide has, of course, become in the popular consciousness, especially during the COVID-19 pandemic, where people were forced into their homes, and even essential services, access to income supports, were done almost exclusively online. Registering for vaccine appointments. We heard of all of these services popping up to support people to register online who otherwise wouldn't be able to do so. Now, the digital divide, as I mentioned, is a multidimensional phenomenon. And I'm not going to go through these two pieces of work in any detail, simply to point to them as documenting the empirical literature on the identity and social location characteristics that indicate the existence of a digital divide or predict an existence of a digital divide. So, this work illustrates that this is an intersectional phenomenon. It's complex, and it comes from a variety of intersecting systems that lead to these three levels of the divide that I've outlined. This is from some work that I did with some colleagues in the United States, where we looked at the dialogue happening around how to promote health equity in the context of virtual care during the pandemic. And we're happy to see that there's a complex literature acknowledging the complexity of the digital divide as a challenge. There were recommendations made at the level of policy and government. This is about enabling access and requiring inclusive design at the level of the healthcare organizations and health systems, ensuring that that technologies and virtual care are tailored to specific communities, and at the level of the community and patients, partnering with providers to share views. So the point being made here is simply that there's no single simple solution to the digital divide. It's not only about making broadband internet access available, across an entire geography. It's also about literacy and opportunity to execute skill sets into successful outcomes in various ways. Now, this is a classic paper in disparities and innovation, health disparities and medical innovation. So, for those of you coming to this from economics, if you're not aware of this paper, I would suggest looking it up. And the key point being made in this work is that complex innovations benefit more educated, higher income patients, and simpler innovations benefit everyone. So this is a way to counteract the digital divide, is to ensure the availability of much simpler approaches to solving problems. And I wanted to just share a recent experience of a paper that was recently accepted to Nature Digital Medicine, led by a colleague, Tyla Thomas-Jacques, who was with us at Women's College Hospital as a Master's of Public Health student and research assistant, and now has moved on to the Ministry of Health. And this work was also done with colleague Trevor Jameson. We wrote this, a commentary paper, essentially suggesting that if virtual care is going to be delivered equitably, that the telephone needs to be retained as a modality of virtual care delivery. And it was a pretty standard argument, very much aligned with the paper we're showing now. Simpler innovations benefit everyone. More complex, video visits are more complex. There's a digital divide and not everybody has access. And there were 3 reviewers. 2 of the reviewers really liked the paper. They wanted to see it come through with some sort of minor modifications. And one reviewer was, real advocate for quality in virtual care and was really advocating for video visits as the higher quality approach, and thought that the argument we were making was overly simplistic, when really we were simply saying that simpler innovations benefit everyone. And if you want the equitable delivery of virtual care, you need to retain the possibility of simpler approaches, modalities to delivering that care. So, I think there's an interesting dialogue here around quality and accessibility, and it's not simple. I don't want to present this in a simplistic way. So this was a recent experience that resonated strongly with the core messages of this paper, which has been influential in my thinking. So that concludes the section on the digital divide. The simple availability of digital health technologies does not mean everybody has access to those technologies, to the benefits of those technologies. And in fact, where technologies are complex, the benefits accrue to the people who have the resources to access those benefits. That results in widening health disparities. So we'll move on now, shifting a little bit away from the digital toward underinvestment in upstream determinants. And I'm sure everybody tuning in today has seen a visual like this. This is from the Center for Disease Control in the United States, visualizing the social determinants of health. So, education access and quality, economic sustainability, social environments, neighborhood and built environments, and of course, access to quality healthcare. These things influence, they determine health status in the sense of health and well-being. Now, that picture is a sort of depiction of this theory of fundamental causes, which has come in different versions and had different names, but at least in this version is based on work done by Lincoln Phelan and certainly a large group of others that proposes that even when diseases and disease mechanisms change over time, the fundamental causes like income, stability in income and education, they continue to influence health outcomes. So the theory of fundamental causes suggests that these social determinants of health, they have this deep and profound influence in shaping health status and health outcomes, even when diseases and disease mechanisms evolve. So this is, simply a statement of the ways in which the social determinants of health have their effects. Now, so, this illustrates this point that we know that there are fundamental causes. We can name them, income support, suitable, sustainable housing, meaningful education. So we know these exist. So now, we can do something about it. Turns out, that's of course very difficult to do. And I want to move on to talk about this paper by Scott, Samuel, and Smith called "Fantasy Paradigms of Health Inequalities: Utopian Thinking." And shout out to a colleague, Ambreen Sayani at Women's College, who put this paper, this notion on my radar. And I think this is just such a fantastic and challenging analysis of the ways that health systems intend to address health inequalities, to address the impact of the social determinants of health in healthcare systems. So these authors essentially are arguing that the belief that downstream innovations in healthcare can make meaningful impact on upstream social determinants is a fantasy. And they use this deeply critical language of this notion of a fantasy paradigm of health inequality to raise questions about innovations in healthcare that focus on the point of care. For example, connecting people with social work, connecting people with income supports. They challenge the notion that will impact the social determinants of health. Those are not strategies to solve the negative impacts of the social determinants of health as they propose in this paper. And this is a long quotation, please bear with me, but it's worth looking at in some detail. So in that paper, they say, when it comes to setting out visions for reducing health inequalities, strategies tend to provide a list of interventions that focus almost entirely on downstream proximal health determinants. And they list smoking, unhealthy dietary choices, poor housing conditions, failure to use contraception, implying that it's these local instances of things that represent the causes of health inequalities. So, you can see that they're critiquing this downstream focus on the grounds that that's not where these inequalities are coming from. That's the wrong focus, the wrong locus of attention for addressing the fundamental causes, the social determinants of health. Now, what I would say, this screenshot is from a paper that I believe was just published this week, Implementing Social Interventions in Primary Care, led by Gary Block, a colleague in Toronto who does incredible work. And I would say that against this view of a fantasy paradigm, these social interventions have a crucial role in mitigating the effects of the fundamental causes. So, although I think underinvestment in the realities of these fundamental causes is a challenge to the successful effect of health innovation, to the production of health systems as a public good, I do think that these kinds of innovations have a crucial role in mitigating the effects of those fundamental causes. It's about going into it with eyes open, is sort of this overarching point. So that's about underinvestment in upstream determinants, thinking critically about where we're investing our attention in our work on health innovation and on health system change. So fifth and final, I see I'm doing well for time. Fifth and final is, as I've stated here, lack of attention to infrastructure. And this comes from a tradition in the interdisciplinary field of science and technology studies that's, for a few decades now, looked at the infrastructure in our everyday lives that we take for granted. And, this is, so one of the sort of core points that comes out of this body of work is that new technologies earn attention at the expense of infrastructural issues in healthcare. And I have a few examples to share. So one, we have comprehensive home-based remote monitoring technologies, but we don't have a sustainable staffing model for personal support services in the community. That's infrastructural. Personal support, this is the backbone of health and social services more generally. We can't figure that out, but we can develop these really sophisticated technologies where you can stand on a scale and have your blood pressure and all of this taken from your own bathroom at home. So there's a tension here. Why have we, the broader we invested in these technologies and not in this more basic core infrastructural reality? A second example, here in Ontario, we have Ontario Health Teams, an integrated model of care that's intended to sort of parallel accountable care organizations in the United States. But we don't have a scalable model of governance for integrated care. How these organizations, the leaders at these organizations are to work together, are to share accountability. These are the hard parts. This is infrastructural to achieving integrated care and to the success of Ontario Health Teams. I know there are many good people working on this topic now. And then third, we have artificial intelligence for decision support, but we don't have a shared electronic health record that enables the sharing of information across the system in care delivery. So how is it that we've developed, again, the broader we have developed this incredibly advanced technology, but not the basic infrastructure for sharing information in the service of providing care? So these are some examples of where attention has been so focused on new innovations at the expense of infrastructural issues. Much of my thinking on this topic comes from this book by Lee Vinsel and Andrew Russell called The Innovation Delusion. And I want to show a quotation from this book that I think captures the ethos of this point well. So they say, in some ways, maintenance is the opposite of innovation. It is the practice of keeping daily life going, caring for the people and things that matter most to us, and ensuring that we preserve and sustain the inheritance of our collective pasts. And so I would just propose, what do we need to care for that we've been neglecting in our healthcare systems? And that concludes that the lack of attention to infrastructure. Okay, so shifting into the final part of the talk, leading toward the conclusion. Where does this leave us? I mean, this is a lot. These are challenges to the possibility of health innovation serving everyone. These challenges raise the volume on the question of who is excluded from the benefits of health innovation, and what are the consequences of that for our society and our health systems. So where does this leave us? I suggest it leaves us with some important choices. What do we want innovation to accomplish? And one of the strategies for responding to this question is, I think, engaging in our imaginations, in imagining, establishing the prospect of possible futures. Where might this take us? Where could we invest? How important is the financial gain that comes with commercialization for boosting economic activity. It's certainly important. This is a crucial value and has been one of the driving forces of raising the standard of living and quality of life around the world. Do we want to intervene in the precarity and sustainability of housing? And now we have healthcare organizations like University Health Network in Toronto investing in social housing as a healthcare strategy, certainly an innovation. Is that where we want to invest our time and attention? Do we want to advocate for access to broadband internet as a social determinant of health? And my colleague at University of Michigan, Tiffany Vano, has done quite a bit of work on that. Do we want to invest in the infrastructural issues of a shared electronic health record? So this is about acknowledging where our current investments will take us or could take us, and making a choice about where we want to invest in the near term. So on this grounds, I shift toward this focus on responsible innovation in health. And some researchers I really admire have done great work in producing a whole body of research that expands and explores the implications of this notion of responsible innovation in health. And of course, Pascal Lahou, past Labelle lecturer. So a quotation from that paper that I've just shown helps to sort of set the scene for this discussion. Now, again, this is a complex and encompassing notion, so please bear with me through this long quotation. So they define responsible innovation in health as a collaborative endeavor committed to a set of ethical, economic, social, and environmental principles, values, and requirements. So this is, they're looking quite broadly. They're acknowledging the importance of economic, social implications. They're acknowledging the climate crisis. They're acknowledging the importance for some underpinning ethical commitments in this work of innovation. And they apply this perspective in several activities: design, financing, the production, distribution, use, and even throwing away, discarding socio-technical solutions. So this is about looking from end to end. And they acknowledge that this responsible innovation is done to address the needs and challenges of health systems in a sustainable way. Lofty goals. And I think, as I lead into the sort of concluding statements of this talk, that's what I want to leave us with, something aspirational that aligns with these lofty goals. I'm not going to go through this table in detail, other than to draw our attention to the fact that these authors acknowledge that health innovation, it promotes value in a variety of areas. Economic value is there, certainly, economic growth, and investors, investing in technology in order to see financial gain. This is not something to be ignored, but something to be understood. They also outline that value exists in population health, in health system domains, in organization, and in the environment. So they broaden our perspective of these, of where we ought to see value from innovation in healthcare. And again, I would just come back to this point. I'll look forward to some discussion about the real tension between support for innovation for economic gain on the one hand, and support for a healthcare system that meaningfully provide services in an inclusive way. This is a core tension, I think, in this field of responsible innovation. And this system, this framework, has been critiqued on those grounds as well. So continued work needs to be done to determine what kind of teeth responsible innovation has. So on to conclusions, posing this question, where do we go from here? And I have five sort of reflections on where we might take this. First is that, I propose we need to make choices about the kind of future we want and invest our time and energy to achieve it. We are all, making investments with our time and energy now by being present here at this talk and in the work that you do. So how are we investing our time and energy, and what kind of future is it achieving? Second, we need to acknowledge institutional resistance to real change. It's hard to change a system that serves its leaders and professionals so well. And I think this is a crucial reality that we need to grapple with. I grapple with this. I'm deeply served by current institutions, and if I intend to promote institutional change, I need to contemplate that deeply in order to understand how. Third, we need to shift focus away from emerging technologies toward innovation that serves structurally marginalized communities. Now, as somebody who has spent a great deal of time on the ethics of artificial intelligence and related emerging technologies, I don't say this lightly. I think that emerging technologies absolutely require attention. I think that the amount of attention they have earned, particularly recently, has been disproportionate when put into the broader context of the issues faced by societies, publicly funded healthcare systems, and especially structurally marginalized communities. Fourth, I would say we need to balance investments in innovation with investments in boring but crucial stuff. Colleagues who know much more about electronic health records and are much smarter than I have said to me that it's too late. We can't have a single shared electronic health record, but certainly that's an area that requires more work. Fifth and finally, I would say we need to develop stronger and more meaningful partnerships with communities. And this is in an effort to achieve epistemic justice. And credit to my colleagues at Women's College Hospital who have really raised this notion in our work together, raised the importance of this notion, and it helped me personally to understand the long commitments and time and energy required to really build these meaningful partnerships. Now, in this sense, epistemic justice is bringing other ways of knowing to the table. The decisions that are made around where these investments go, the decisions that are made setting directions for health policy are made by particular kinds of people. How can we bring other ways of knowing and other voices to those tables, beyond simplistic approaches? And with that, I'll say thank you so much for your time, and I'll look forward to some conversation.
Thank you very much, Professor Shaw. I think I can speak for all of us when I say that we learned a lot and really enjoyed your talk. Can we pause and just have a round of applause, please? Reactions. Yeah. We will have plenty of time to ask Professor Shaw questions after our discussant's presentation. So please hang on to any questions that you have. I'm now excited to introduce our discussant, Professor Sarah Labelle, who will be using her expertise to help advance what we've just heard. Professor Labelle is a professor in the DeGroote School of Medicine here at McMaster, and her work focuses on entrepreneurship, innovation, and health systems transformation.
Thank you so much. Excited to be here. Dr. Shaw, that was an excellent presentation. So I'm going to begin by mentioning a not so massive surprise to everyone, I'm sure, which is that we have mounting pressures on the healthcare system. And I'm going to tell you about 5 challenges to do with rising costs, changing demographics, unequal access to care, an increasingly insufficient number of health providers, and rapidly shifting patient sentiment. So first, according to the Canadian Institute for Health Information, total health spending will actually reach $300 billion in 2021. This means an average of $8,000 per Canadian, representing 13% of Canada's GDP, up from 10% from just a few years ago. Second, the population is expanding and aging at unprecedented rates. Between 2020 and 2030, the percent of Canadians over the age of 65 will increase from 17 to 23%, representing a significant increase in individuals with chronic disease and comorbidities. Third, individuals who live in certain communities or in rural areas that are significantly disadvantaged, they can't access care when they need. Fourth, health providers are burning out. Even before the pandemic, 1 in 3 providers met the criteria for burnout. This impacts not only their well-being, but also their ability to deliver care. And fifth, patients demand more value from their care. Over 70% of them actually access internet and social media to learn more about their health. And yet knowledge translation efforts don't really focus on keeping pace with that, leading to a lot of misinformation and confusion for many. The time to address such mounting pressures is not when they lead to a full-blown health system crisis. The time to address such mounting pressures is before we enter such a crisis. The time is now. Now, the pandemic has given us a sneak preview of how our health system works under immense resource constraints and pressure. We have seen the difficult choices that need to be made when we run out of beds. We have witnessed the emotional strain that a state of constant change and ambiguity has on people. On the bright side, we learned that our healthcare workers and administration are incredible. Even in times of chaos, they persevere. On the not so bright side, they need to adapt to survive. Survive, not thrive. And herein lies the challenge. Healthcare is employing a defensive strategy, reacting to triggers as they happen. Pandemic aside, how do we change the narrative to employ an offensive strategy that proactively identifies areas where we can do better? How do we resource ourselves and build system capacity to be better? Assuming that the point of innovation is to create new value and improve healthcare, are we spinning our wheels or are we actually going somewhere? That's precisely the question that Dr. Jay Shaw just asked us. Now, we hear it all the time. We are moving towards healthcare that favors delivery of the right care at the right time to the right person in the right setting. Simple to say, but exceedingly difficult to get right. Even now, we are thinking about Ontario health teams, which promise new care delivery models that integrate care from different organizations. Even now, we are thinking about what virtual care looks like after the pandemic. We know that virtual care is not accessible for all, and it's not for everything. We know that other digital interventions coming out should be clinically validated, and we even have researchers at McMaster University that are working to streamline that process. Simply put, there are always going to be challenges with innovation, but the question is whether there is a way to approach innovation to anticipate and avoid these challenges in the first place. Dr. Shaw provided a critical analysis of whether innovations in the domains of digital health and new care delivery models are doing what they say they will. He questioned the role of technology corporations and our tendency to overinvest in innovative technologies without the much needed critical analysis of their ability to deliver. He reflected on whom innovation serves, the absence of system level perspectives to understand how innovation fits into the bigger picture, and limitations to our individual, organizational, and system level capabilities to successfully implement brilliant interventions. It's a fair question. Is innovation achieving its goals, or do we suffer from a constant need to chase after the new bright and shiny object, only to be disappointed when it, yet again, doesn't do exactly what we were hoping it would do? To explore this question, I'm going to reflect on two perspectives: the perspective of the innovation builder and the innovation recipient. In other words, the perspective of the innovator and the perspective of the innovation beneficiary. I work in the world of health innovation and entrepreneurship. For one area of my work, I train individuals to recognize opportunities for innovation and to go after them. These are the emerging innovators. The process of new value creation is messy and convoluted. It requires a mixture of curiosity, creativity, detail orientation, people skills, health system understanding, and a special kind of perseverance that makes you understand when you should keep trying and when you just have to let it go. Innovation is extraordinary when it works, but it usually doesn't. Over 90% of the time, it doesn't, for many reasons, including but not limited to a lack of product market fit, poor team dynamics, competition, running out of capital, but such is the life of an innovator. Together, innovation teams envision ways in which our future might be different by identifying unmet needs and then working very hard to develop solutions that are desirable, feasible, and viable in the long run. The teams tell themselves to fall in love with the problem they aim to solve rather than the solution. This shift in fixation from solution being built to problem being solved is nuanced, but it reminds them to always keep going and pay attention to what matters, serving the people with the problem. In another area of my work, I collaborate with innovation recipients or beneficiaries, organizations. I work with leaders to build capacity for their health institutions to support health innovation. But when speaking with such colleagues, the conversation is often around decision making. When considering the topic of innovation, there are too many unanswered questions. For example, how do we bring innovative technologies that have into our existing organization when they've already been developed? If we do so, how do we actually identify the right solution for our context, validate it, and then make sure that we build enough capacity to ensure we can fully make use of it? Do we avoid these questions and develop an innovation in-house? Or do we simply ignore the problem until it comes to the top of our list of strategic priorities, and it's less about convincing individuals of the need for change and more about riding a convenient wave of political will that suddenly accelerates decision-making? These are all big questions, and some of them are a little bit uncomfortable. Sometimes it seems like groups are paralyzed into indecision because they endeavor to get everything just right. If I were to consider innovation adoption and risk tolerance across what my colleagues call the innovation diffusion curve, where there are early adopters of change and change laggards, I would plot most healthcare organizations somewhere in the middle. Without competitive pressures, funding to explore innovative solutions, and an organizational culture that considers innovation as a risk mitigation strategy rather than a risk in itself, the incentives simply are not there to make things happen. It is easier to stay the same until we see those large-scale randomized clinical trials, publications, and other organizations taking a step forward. And then we adopt innovation to keep up. Sometimes I wonder whether innovation is more often seen as a proactive or reactive strategy. It can be both. However, we all know that reactive strategies are often decisions made under pressure, and sometimes there is a lack of choice. In these situations, does this make innovation less thoughtful, less considerate? Do we stop ourselves to ask if we all have a deep understanding of the unmet need or problem we need to address when innovations are being brought forward? Does the healthcare system have the capacity to work with health innovators and give them the information they need to address unmet needs? Do they have the capacity to do health innovation work in-house to solve these problems? We forget sometimes that innovation is not about using the latest technology or designing the coolest solution. It's not about artificial intelligence and blockchain. Innovation is an act of servitude. It is an unwavering commitment to unmet human, organizational, and system needs. When we decide to resolve an unmet need, we need to understand why that need exists in the first place. We must push ourselves to think differently, deepen our understanding of problems, and consider options that have never been tried before. The discussion today leads me to believe that maybe we don't know exactly what we want innovation to do. And it makes sense. In a system that is as risky and dynamic as healthcare, we fight for stability. But demand for healthcare is quickly rising to exceed system capacity unless we learn how to leverage data about the future to create opportunities for change that work in our favor. The innovators and innovation beneficiaries must communicate and collaborate. We must expand the circle of care to include other organizations, allied professionals, as well as innovative people, companies, and the solutions that are brought forward. We can't address the challenges in healthcare with the same thinking that created them. The framing of unmet needs requires us to focus on outcomes and address the disconnect between how healthcare institutions are rewarded and patient values. Dr. Anne Snowdon, a leading thinker in this space, actually calls for a shift in focus from operational effectiveness, so length of stay, readmission rates, quality measures, to what patients care about, which is autonomy and empowerment in managing care, personalized approaches, and collaboration with health providers to make decisions on health and wellness. We need to revisit the outcomes we are measuring. Nuanced challenges, such as digital divides that Dr. Shaw articulated, can be addressed through supporting and working with health innovators who seek to develop interventions for underrepresented populations in remote areas. For instance, telecommunication systems for healthcare that use significantly less bandwidth relative to popular solutions. People who are doing this work exist. Those who are close to the unmet need have a better understanding of it and can develop solutions to solve the problem. How is the healthcare system supporting those? Let's agree that we all want better outcomes alongside enhanced patient and caregiver experiences. None of us wants to waste healthcare dollars on innovation that doesn't work. It is our responsibility to take charge of change, not be the victims of change. To make innovation better, I challenge us to seek deeper understanding of problems. I challenge us to understand that we need innovation to do, the values with which it must align, whom it serves or doesn't serve, and the outcomes we must achieve. The framing of unmet needs to explicitly identify the problems, people impacted, and intended outcomes is the beginning of the so-called responsible innovation that Dr. Shaw is calling for. Breaking down the barriers to information about unmet needs is important. We should all embrace curiosity, creativity, detail orientation, people skills, health system understanding, and that special kind of perseverance that knows when you should keep going and when you should simply let it go. Use risk analysis to find ways to mitigate risk, rather than yield points of indecision about what innovation should do to meet unmet needs. While innovation sometimes misses the mark, herein lies a wonderful opportunity. There are two key parties here, the innovators and the innovation beneficiaries, two readily identifiable groups of individuals for whom improved communications and collaborations is a direct consequence of intentional efforts. Therefore, the responsibility for better innovation lies squarely in our hands. And I don't know about you, but I actually find that particularly empowering. Now, I have a few questions for Dr. Shaw based on just the analysis of the presentation, all the comments that were brought forward. But at this point, I think it would also be fair to invite the rest of the audience to engage in a little Q&A. And I think the best course of action to do that is to list the questions in the chat, and we'll get to them in order of their appearance in the chat, if that works for you, Alex. So Jay, Dr. Shaw, if you want to start engaging in a little bit of a discussion, I have 3 questions, and we can answer them in whatever order you'd like. But first question is, given the tensions between making a financial return and ensuring that we provide value for healthcare, how might we work with or make recommendations to capital investors to enable improved selection of technologies or companies for funding? So how do we make better guesses of what's going to work and ensure that it's the right fit for what healthcare needs? Second question is disruptive innovation possible within this responsible innovation framework? So that type of innovation that requires systems or behaviors to change in response to a new form of value. And third thing is, given the complexity of healthcare and the number of individuals involved, how do we actually work to prioritize unmet needs that require our attention? And I'm really looking forward to engaging in a little bit of a back and forth with you on those.
First of all, Professor Lau, thank you so much for that beautifully written, prepared response. I think, you touched on, you expanded understanding, I think, of the topic by focusing on unmet need, and also clarified the realities of, stakeholder groups, people doing this work in the innovator and the innovation beneficiary. So I really appreciate that. Maybe I would put it back to Alex. Alex, do you have a preferred way that we go from here, or would you prefer that I respond to Sarah's questions first?
No, this is however you'd like to do it. Maybe we can start off with some of Sarah's questions, and I see some questions coming into the chat as well. So if you want to go through those how you want.
Okay, sure, certainly. So maybe, Sarah, maybe I'll take your questions as sort of a starting point, and we can have a bit of dialogue about that. And in response to your first question around selecting investments to achieve particular kinds of goals, to achieve a more inclusive health system, I think that that's certainly possible to an extent. And it's like we see University of Toronto just recently announced divestment from climate damaging financial investments. And so, certainly there are ways to steer investment dollars away from business models that are extractive and exclusionary, and toward companies that are doing inclusive design processes, showing thoughtfulness about business models end to end, and have done the work to identify, as you've so eloquently put it, those unmet needs that matter, that they're committed to. And I think here's where we butt up against the limits, I think, of that strategy or approach, in that fundamentally the mission of investors, particularly at the level of firms, responsible for capital investment, is not social responsibility, but is rather, financial return. And here's where we see this conflict, this tension between these logics, and where investments are for financial return on the one hand, but they also deeply shape the innovations available in the health system. And if a social responsibility perspective was forefronted in the investment, then particular kinds of companies would be invested in. I think that is a tension. I think that that's exactly the kind of issue that responsible innovation is intending to address. But I think there are real challenges in making that happen. I'm sure there are investors out there who are good-willed, good-natured, and want to promote a social mission with their investment. And I'm also sure that there are many who are not. So I think that acknowledging that the world is made up of a bunch of independently acting parties connected in various ways, but with their own incentives, and own orientations to the world. I think that's the reality of the challenges that we face. So, I was reflecting on this as you were speaking, like, I don't have a solution, to that. And I think that's part of our mission in this kind of academic work on health innovation and health system change, is to raise questions that encourage us to think differently. And I think this is one. How can we grapple with this tension? Where are the points of collaboration? Where are the things that need to change? And of course, part of our mission academically is to come up with those solutions. I'm just not sure. And I think responsible innovation is a step in that direction, but that there are challenges associated with the financial capital system we find ourselves in, that probably need to be addressed along the way. So maybe I'll leave it there, Sarah. I'm not sure if you have a response or if you suggest we look to
I think those are excellent points. And I completely agree that we're all kind of fighting for different interests. And I mean, the act of trying to preserve self obviously influences a lot of how we proceed with what technologies we use, what we don't use. And for the investment firms, it's a lot of trying to minimize risk by kind of having a portfolio of different companies with different risk levels, and ultimately trying to go for one or two wins out of many that we actually make an investment in. I think one of the key things to consider is just how difficult it is to create companies, and how difficult it is to secure capital, especially in Canada. It's one of the biggest challenges that innovators face. And capital in the States, in many other countries, it's easier to come by, but within Canada especially, it's already very, very difficult, especially for earlier stage innovations, to secure a little bit of funding. And it's interesting because there's still that demand that will ultimately drive the success of a lot of these technologies. And so if we consider that things are successful not just because of investment, but because there is demand for what you are putting forward, we might even consider that perhaps individuals, when making decisions, aren't going for the most ethical of solutions, but they are going to what serves their needs. And so perhaps there's a little bit of a different approach that may be required for advancing the success of those entities that are more ethical, I guess, in how they consider the innovation development, but perhaps because of a niche target market or something along those lines, they don't actually benefit as much from so much demand that they're able to be sustainable in those kind of big hits for the investment firms. So it's an interesting space to get into. And I mean, I think that we could talk about that for hours.
I just really quickly, I think that's such a great point. And I would want, if we were to take the next step down there, and I don't think we should, but to complicate the idea of demand, like how do people make decisions about which technologies they interact with? And I would say it's not as simple as it seems, but certainly the beneficiary, the purchaser, the customer, the user, whatever the language is a crucial site of intervention in this work as well. Yeah.
Mm-hmm. Awesome. Do we want to go with an audience question, or do we want to go with
my
second question?
Okay. Yeah, I think let's do that. And I think a couple of them touch on some of the questions you've asked as well. But I think just before you pasted your questions, I see Niku.
Yeah. So I'll just read out the question so that everyone's in the know. So the question is, you mentioned that there needs to be a larger focus on simpler solutions rather than complex ones to ensure equitable access. The question is, do investors have different perceptions of these two levels of complexity? And is there a trend of investing more in complex solutions?
Yeah, thanks, Niku. Interesting question. I think I want to answer a related but different one, which is just around the role for health systems in this kind of thing. And, I learned from Danielle Martin, now in the Department of Family and Community Medicine at U of T, about framing the healthcare system as a redistribution of wealth. Healthcare is funded, decisions are made by governments, it's funded by taxation in order to ensure that this essential public service is available for everyone. And in that capacity, leaders, governmental leaders have the responsibility to decide what kinds of services are available, to publics. And so I would say that as opposed to thinking about what investors invest in, I want to just acknowledge first that healthcare policymakers have choices about what to invest in as well. So healthcare policymakers make investments by being the largest customer in the province for any given innovation. And I think that's something that many innovators, grad students who have built a technology haven't quite yet understood, is that to become a part of the publicly funded health system, often the publicly funded health system, the government, needs to be the primary payer for whatever technology is being offered. So as the primary payer, it's up to the government to decide, or health system to decide, are we going to fund the phone or video visits or both? And so, in that case, there's a different logic acting on a publicly funded health system decision maker about where they will invest their funds. Now, if you ask about investment firms, the way capital investment works, I think you've posed a really interesting question, and I don't have the answer for you. Sarah, maybe in your experience, you have thoughts about this. I think it would be really interesting to look at this question interviewing investors of digital health technologies in order to find out how they think about complexity and simplicity and the implications of that for sort of entry into markets. Sarah?
Yeah, so no, it's a really good question. And I mean, simplicity will always win. I think we kind of want to talk about, are we solving simple problems, or are we solving complex problems through simple solutions? And so if there's a benefit to engaging in a solution that makes our lives easier, that increases benefits, that enhances outcomes for the patient or for whoever is actually using the solution in question, they will always be able to then take that traction. That's what we call it, being able to demonstrate traction, people's willingness and demand for a particular proposed technology. And then the investors are looking for exactly that. Something that is complex and just no one knows how to use it, you'll you'll have a lot of challenges with being able to demonstrate traction, with being able to complete pilot studies, with being able to demonstrate that you have a fan base, for lack of a better term, to the investors in question. So it always comes down to, do people understand it easily? Does it provide benefit? And if the answer is yes to those questions, then they'd be inclined to participate. But if it's too complex to even understand, then no. And I think that's part of what we sometimes overcomplicate in innovation. We tend to over-featureize, if you will, solutions, because we think that, oh, you know what, we're going to solve all the different problems. But usually people don't use all the features. They just want something simple. And so if we're able to actually follow the lean startup method, if we're able to start slow, develop a minimum viable product, and then build up off of that to develop complexity, it's a different kind of play, because then you're actually responding with complexity to user needs, as opposed to going in with complex solutions, no one actually wants it, and then investors will never actually want to participate. I'm not sure if that helps with the question, Niku, but the answer is it depends, but you never want to introduce complexity without confirmation from the user base or whoever is going to be making the purchasing decision that that's actually something that they want.
That's definitely helped. Thank you so much.
All right, which audience question or my second question?
I think this one gets at your question. Katrina's question, I think it gets at one of yours. So should we go to that one?
Sure. So how can one determine that a problem is really significant and predict the effects it will have on society overall once it is solved?
So Sarah, your third question, how do we prioritize unmet need? I think those are really closely related. And I think, I think this is a really, really important question. When I refer to publics, I pluralize that because I don't think it's accurate to view the public as a monolith, as a single entity, because publics are extremely diverse, particularly, here in Canadian cities, I mean, in Canada more generally, but I would say, sort of everywhere, publics are extremely diverse. And so the belief that one can select the most important problem, particularly from the privileged position of the ivory tower, so to speak, I think there's real risk in that. And so there are ways to expose yourself to more kinds of unmet need, more kinds of challenges, so that you can develop experience in understanding what the nature, the character of those unmet needs. And this is where in my work, I'm investing in building relationships with community agencies and community members, in some ways, like, so that I don't need to risk making mistakes about what those unmet needs are. It's by going out, partnering with communities, developing those relationships, those partnerships, that the crucial unmet needs will come to you. And I think so that's a reality. It takes a long time. It's hard to do in a pandemic because, as sort of my colleagues and I have been discussing, it's about creating spaces that are inviting for community members to come into. Many communities have distrust, earned rightful distrust in actors at universities and in health systems because of the historically extractive relationship between the two. So what I mean is, university-based researchers going to get data from communities and disappearing. And so, thinking differently and committing to building those relationships in order to understand the nature of those unmet needs, I think is one really crucial, investment. But I would also say that there's lots in the literature. And if if you have a particular skill set, a particular interest, look into that literature to see what people in a community have said about what the major challenges are. There's so much work that's already been done, that's already out there. I think that's a really important strategy. third and final, I'm working on a project right now that's a strategic foresight project, where we're sort of canvassing widely to understand trends that are shaping community care, health equity and community care, speaking with sort of select stakeholders, community members, in order to generate these, ultimately fictional, but potential scenarios of futures to really think, to anchor ourselves in some concrete detail about, if we keep going like we're going, where are we going to end up? What might things look like? And that focuses attention on some of these major challenges: the climate crisis, growing economic inequality, the real estate market in Canada that is, extremely problematic. What are the implications of those things, and how do we think about what they're doing in healthcare, how they become manifest in healthcare, and what's our response? So I would say important partnerships, looking in the literature, and anchoring yourself in thinking about concrete details about where things will go or could go in the future are a few ways to think that through. Sarah?
No, great answer to the question. And just building off of what you're saying, totally agree. And part of what we sometimes do within the innovation training space is we focus on volume of unmet need. We're focused on be as generative as you can be in identifying challenges that exist for different types of individuals, frame them as those unmet need statements that have the problem, the population of interest, and then the intended outcome. And then we prioritize them using decision matrices. And for just quick reference for individuals, I'm not going to belabor the point too much. We focus on things like the number of people who are impacted by that particular unmet need. We think about how much they're impacted. So the size of the problem for them, is it wasting money from the healthcare system? Is it causing a lot of reduction in quality of life having this problem? And sometimes we also focus on the number of solutions that actually exist to meet that unmet need, because in certain circumstances, there's literally nothing. And so perhaps that's of higher priority than something where actually there are, 10 solutions already. They're not exactly perfect, but they do help to reduce the burden of the problem at hand. And so those are some additional layers of consideration just when you're looking at those unmet needs and seeing what might have the biggest impact on society. The foresight stuff is really interesting. I think trend analysis is just something we have to talk about a lot more frequently. Looking to the future, trying to look at strong signals, weak signals, trying to understand kind of what's going on and how we can prepare for the future before it happens. And I just wanted to flag this because this was a realization to me about 1 or 2 years ago. The literature is a great place for information, but be also wary and cognizant of whose voice it represents. I did note through some of the training that we were doing that patient voices weren't exactly being articulated in the literature. There were certain groups of individuals where if they articulated needs, for instance, you could find nothing to validate them in existing and published reports. And so sometimes when we're looking to find solutions or find unmet needs for niche populations or those who are underserved, they are underserved. Right? They are underrepresented, they are underheard. And so in those situations, perhaps relying on different approaches to having focus groups or interviews with these individuals, as opposed to relying on the literature, might be a better way just to make sure that you're able to still listen as opposed to confirm and keep them in mind when you're designing innovations or trying to push something forward. That's the only thing for literature. Okay, next question. So, Jay, do you want my second question or do you want Niku's second question?
Why don't we go to Niku? Yeah.
Okay. So when thinking about focusing on maintaining existing infrastructure as opposed to innovating new technologies, how do we strike a balance between troubleshooting a flawed system versus reinventing it altogether?
Another great question, Niku. Thanks. And I think here, this idea that we have choice about this is something I would want to problematize. And I mean, I suppose I'm thinking in terms of something infrastructural. I'm thinking about electronic health records, and the idea that like we could reinvent that altogether is, it sort of doesn't make sense to phrase it in that way, because there is no single actor responsible. We have, I think, in primary care, 23 or 27 electronic medical records in Ontario, which are, privately owned and operated. Investments have been made, machine software have been purchased. And the idea that we could undo that the government could undo that, I mean, it's just simply not possible. And this is why, colleagues who do work in this area say, we can't go back in time. You can't unfry an egg or whatever the saying is. So, we need to look forward and think about what are ways to promote interoperability, data standards, technologies that can allow communication between these kinds of systems. So I think there's this, the forces that dictate responses in this kind of circumstance go well beyond decision making toward the investments that other people have made, the legal and social structure of our health system, and so on. So yeah, Sarah?
I think it's a very challenging question. I think it's sort of, well, do we reinvent the way we do everything, or do we try to incrementally make improvements? It really depends on the significance of the problem or the unmet need at hand, and the size of the pain and the size of the improvement that you could foresee with the proposed solution. So if you see that, for a year, like let's say with the transitions to a new EMR platform, let's say for a year, it's a huge burden, but once you get to the other side, it's going to be a significantly improved experience. And then it's worth it. But I think it's one of those areas where the pain needs to be really big for you to move mountains, for lack of a better term, to change a system fully, and then kind of reap those benefits. But in most cases, and I think this is reflected in quality improvement, is the focus. Many times in healthcare, many times the benefit isn't that big to be able to go through the pain and suffering to actually change things completely. And so we go for incremental solutions that work, right? But I think that's just the way that we have been making decisions so far. Jay, do you want to respond to that?
Yeah, thanks. I just want to add, it prompted a thought, an example of a case where, yeah, just got rid of what had already been laid down in Sidewalk Toronto, or Sidewalk Labs in Toronto. And voices were loud enough fairly early in the process, pointing out, real challenges in governance and cost sharing and profit sharing, to the point where the decision was made that it just simply wasn't worth it. And despite the millions of dollars already invested, Google pulled out of the city. So it does happen. It requires, such forceful leadership, as we saw from the Block Sidewalk movement, to sort of make that happen.
Definitely. Okay, next question from Tiffany Green. You mentioned the need to direct innovations in ways that marginalized communities can benefit from them. However, the exclusion from these groups in the health innovation space makes this challenging, particularly as lived experiences matter when it comes to designing user experiences and tackling challenging problems. How might we address this obstacle?
Yeah, I would say, first and foremost, the human resources function of organizations in our society is like the battleground for racial justice, and like social justice more generally. Like the historical and contemporary exclusion of people from particular social locations in meaningful employment is, I think, one of the most important ways in which inequity and injustice is perpetuated. So, I would say that hiring disabled people, hiring Black, Indigenous, and other people of color, like this is the way that that you promote inclusion in the design of technologies. And it seems to me that there's been a real investment and a lot of energy behind that recognition, particularly since the murder of George Floyd last summer. So I think that is a really crucial strategy. The second thing that I would say is around pointing to work on inclusive design. Jutta Treviranus from OCAD in Toronto has done some incredible sort of path-breaking work on that. And I mean, of course, there's a ton of work on inclusive design and ethical co-design that explores ways to develop relationships with community members that are that allow for meaningful input and collaboration in the design process. So I would say that that's also a strategy worth learning about and looking into.
Just to build on that, I mean, such a tricky space, right? Because I think in the best case scenario, we would have all these innovation projects be co-development efforts, and we would bring people onto teams. We're kind of doing that with veterans. Actually, next semester we're bringing veterans to become part of the innovation teams to get them directly involved with the innovations progression. However, that's really not always possible. And I think one of the things we need to get better at, just within everyone's world, but particularly within the innovation community, is becoming really good listeners, so that when we do engage with community members, we do truly pick up on what is needed. We pick up on how to build rapport and build trusting and nurturing relationships with community members to make sure that it's not just, check, we talk to these people, but it's we have engaged and we continue to engage throughout the process that we're going through to be able to develop a solution that actually works. And it's easy to say that. It's difficult to execute on that because, I mean, it's a space where we're coming from different worlds. We're trying to yield some sort of shared understanding of the situation and where we need to head to make it better. But just overall comment is we need to become better at listening. We need to become better at creating meaningful community relationships where we don't just kind of, after the semester's over, kind of move on to the next group of community partners. And we do also, within the innovation teams we create, need to ensure that there is diversity of everything. Diversity of thought, so different disciplines represented, diversity of ethnic backgrounds, diversity in sexuality, everything. Diversity on all counts. And I think we're getting better at doing that, actually. The problem often lies after innovation teams are formed and you start to raise capital. Then you start to get into bias that's sometimes formed, from investors, from like people who make decisions on behalf of how successful the company is going to be based on money raised or partnerships that are formed. But typically within the innovation team environment during early stage innovation work, we are better at getting that diversity. But again, it's later on that becomes the challenge. Hopefully that's helpful. Jay, do you have a comment in response to that, or?
Just to say, interesting reflection. I hadn't thought about it in those terms before, so I appreciate you sharing your experience on that.
Okay, so let's go on to the next question. So with Dr. Iorio, maybe a parallel with investors in drugs. Okay, so I'm going to read this out. So maybe a parallel with investors in drugs, diagnostic devices, or EMR would help understand if there are different challenges here than we see in other spaces of healthcare. Alfonso, I wonder if you're willing to elaborate on your question a little bit.
Yeah, Sarah, I can, and maybe I wrote it down badly. I was trying to see if the different perspective of the investor and the innovator are very different for a software house aiming to develop the next generation EMR, or a portable US scanner, ultrasound scanner, as compared to someone looking at a higher level digital technology in the space that we were exploring today. And I would argue that it might depend on the way healthcare is paid for, but I would think that in many other fields of healthcare, we have problems about divergence of the investor and the innovator, not just in this field.
Yeah, fantastic point. And thank you for raising the parallel. I think this is one immense opportunity for work in digital health and the role of big technology corporations in particular to learn from past experience with big pharma. And it raises a couple of points. You know, one of which is the fact that with pharmaceuticals, so much of the development of pharmaceuticals is done by massive corporations. And that's a very different model than the academic spin-offs that Pascal Lehoux was studying in the paper she reported. So the relationship of investors to the development of a technology is different for sort of smaller scale startups and smaller companies than for these massive technology corporations. Shout out to my colleague and PhD student, Joseph Donia at U of T, who he and I have done work together acknowledging that the vast majority of technology design is happening in the context of large corporations, which represents very different, incentives, influences, pressures on the design process than those that you get in other environments, like a hospital environment or a startup environment. So I think, looking across the experiences of different kinds of innovation is a real opportunity. The second point and final one that raises is that we have a lot to learn about those incentives and conflict of interest from big pharma. One of the big things that we see now is big technology companies funding academic work in university environments. And what are the parallels between that and funding from big pharma? So I think there's lots of questions to be asked or that can be answered by exploring the parallels and learning experiences from big pharma or diagnostic devices or other devices as well. So great point.
Thank you very much. And since I've spoken, I was unfair not to congratulate for the excellent presentation and very insightful viewpoint. Thank you.
Well, thank you. Great. Sarah?
Thank you. So I'm going to move on to the next question. I think I have nothing to add to your reflection, Jay, but I agree that different innovations very different, and there's different things that we can learn from the entities that are actually pursuing that very different work. I will say this. For some reason, I do think that there's a lesser appetite for us to work with big pharma relative to perhaps smaller biotech companies, ones that are trying to do less capital intensive innovation. I'm not sure why that is. I think there's historical reasons for that. However, I think it's getting better over time. I mean, just full disclosure, because I think we all have to disclose our conflicts of interest, but I am part of a study that is funded by Sanofi Pasteur, and they're actually interested in investigating reasons why there is vaccine hesitancy, right? In order to build out new business models around how we actually get vaccines to people. And so there's lots of great thinking going on in collaboration with industry partners. And I think it's our responsibility to kind of think about how can we engage with each other in ways that are mutually beneficial, as opposed to maybe secluding ourselves and reinforcing that what is it called again? The white tower mentality, and kind of protecting ourselves from things that we think are bad, but really we just don't understand. So I just encourage everyone always to look into your biases, check your biases, and don't let them stop you from what could be a fruitful relationship. Okay. Sorry, I thought I had no reflection, but apparently I did. Maggie, I wanted to get to your question now. So which level of government do you believe is most influential in enacting responsible innovation initiatives? How does a concept so all-encompassing get operationalized in a version of Canadian Federation that is as decentralized as ever? Good luck, Jay.
Thanks, Maggie. Hi, and thanks for your question. This is a crucial point and a widely shared and underlying critique of responsible innovation as an approach. Responsible innovation really grew up in the European Union, particularly around emerging technologies. And some of the critiques that grew up along with it were this question that we sort of have raised around what's the incentive of innovators to engage with a responsible innovation discourse in the first place. So, I would say when you pose the question, which level of government, the federal government has already very explicitly outlined an engagement with inclusive innovation, supporting that very explicitly in their work. And the extent to which they have power in doing so is with their wallet. By procuring innovations that are done in an inclusive or responsible way. I think that's the extent of influence that a government can have. By the same token, domestic healthcare systems in the Canadian provinces and territories, they also have, their procurement function, which, given their mandate toward public service, it makes sense that procurement would happen from a responsible innovation perspective. So my sense is that actually would be sort of diffuse across many actors. And I think that's one of the things that's challenging about responsible innovation, is that there's no single individual stakeholder group who's the sole responsible party for implementing the approach. It's about a culture shift. It requires specific, different actions on behalf of a variety of different stakeholders, including funders and procurers, but then also including the technology companies who are hiring, more diverse staff members and so on and so forth. So, I would say no individual level of government, it's shared, it's about a culture shift, but there are certainly things that a diffuse stakeholders in governments can do.
Awesome. My add-on to that is that much of the time, this is not about levels of government. This is about individuals in positions of influence and power. And I love to use this example because I think he's a fabulous leader and driver of change in our health system. But the current CEO of UHN, the University Health Network, previous CEO of St. Joe's Health System, Kevin Smith. So he actually was one of the biggest proponents of bundled funding at the very beginning when it started, and much of his ability to influence and convince people of the power of that has actually resulted in very successful programs like integrated care models. And also, interestingly enough, is a huge influence on how the Ontario health teams are currently being structured. And so I just say healthcare system change is slow, but it's about the individuals who have worked to get into certain positions where they have the ears of certain people, and they're able to exert influence in order to create positive change. All right. So we're at 4:57, and I love to end things on time wherever possible. So I'm going to say pause for questions. Thank you so much, everyone, for being part of this conversation. I know we've been here for a while, but kudos to you for listening to the lecture, then my spiel, and then engaging in Q&A. The questions were excellent, and I really appreciate you being here with us tonight. I'm going to pass it off to Alex just to wrap things up for us.
Thank you so much. I'd just like to echo that. A fantastic lecture, fantastic discussion. Thank you all for being here. So yes, we've now come to the close of this year's Labelle lecture. Thank you for joining us. And again, a huge thank you to Professor Shaw for his lecture and Professor Lal for leading the discussion. This session is being recorded, and I believe we'll be making the recording available at some point in the near future if you'd like to go back and listen again. And so thank you all and take care.
Thank you. Thank you, everyone. Jay, pleasure.
Yeah, thank you, Sarah, for your great dialogue, and thank you everyone for being here.